Hello, everyone. We're just going to wait another few seconds for people to hop on and then we'll begin. Let's go ahead and get started. We'd like to welcome everyone to the webinar today, where we are going to be talking about the impact of obesity on cardiovascular disease and other metabolic conditions. I'm Mandy Sankuler, your Director of Partnerships and Communications here at the Mended Hearts, Inc. And it's my pleasure today to moderate and introduce you to our two excellent speakers. And I will do that in just a few moments, but first I want to go over some brief housekeeping items. Please remember that all attendees are in listen-only mode. We will not be able to answer any questions related to your specific condition, but we do encourage you to go back to your healthcare provider and ask them any questions you might have. Please type your questions into the Q&A box so that we can answer them at the end of the presentation. And remember, this webinar is being recorded and will be available on our website at mendedhearts.org and on our YouTube channel. And we'd also like to take this opportunity to thank Novo Nordisk for partnering with us on this educational webinar. Without their support, we would not be able to bring you this important information. And now I would like to introduce you to the first of our speakers, Dr. Martha Gulati, who's the immediate past president of the American Society for Preventive Cardiology. She's a professor of cardiology at the Smith Heart Institute at Cedars-Sinai in Los Angeles, and is the director of prevention, the associate director of the Barbara Streisand Women's Heart Center, and holds the Anita Dan Friedman Endowed Chair in Women's Cardiovascular Medicine and Research. She was formerly the inaugural chief of cardiology at the University of Arizona, and she's the author of the bestseller, Saving Women's Hearts. She served as the chair of the National Chest Pain Guidelines from the American Heart Association and the American College of Cardiology that were released in 2021. And we are certainly honored to have Dr. Gulati here presenting for us today. And we'd also like to thank the hospital she works for, Cedars-Sinai, for helping to facilitate this partnership. And lastly, I'd like to introduce Jesse Hennen. Jesse's heart journey began in 2013 when he was rushed into the emergency room where he was diagnosed with AFib and blood clots. After 8 years of managing his heart conditions, he was told he would need a left ventricular assist device and was put on the heart transplant list. Since 2021, he has battled his weight in an effort to maintain his place on the transplant list. Jesse is an MHI Action Network champion who recently traveled to Washington, D.C. to share his story with legislators. So you're going to hear from Jesse a little while, but first I wanted to introduce Dr. Gulati, who is now going to share her screen. Thank you.
All right, can everyone see my slides? All right, great.
We can, you're in presenter mode.
Excellent. So I'm going to be talking mostly today about weight loss drugs, because that's actually a lot more exciting, I think, for our medical community, but also for our patients. I will touch on other things related to weight loss as well, though, because it is important for you to know your options. But I just want to make it clear, I'm probably going to talk a lot more about weight loss drugs. So I have no disclosures related to this presentation, just so that you know, I don't take any funding from any of the makers of these drugs. I do have NIH funded research, hopefully, and from the Department of Defense as well. And I do some work with some of our pharmaceutical companies, but again, not related to this topic. So obesity is such a complex issue. You know, we use this measure BMI that is quite imperfect, to be honest with you, that defines excess weight. So BMI generally is accurate, especially in white people, but not if you're tall. Certainly doesn't work in people who are Asian, particularly South Asian people. And we actually have different cutoffs based on race, although sometimes this is not necessarily fully accepted when we are trying to get medications for patients. They don't seem to recognize that there's differences in BMI. And in fact, BMI should only be a starting point. It's not really the end point. In fact, the WHO, the World Health Organization, defines obesity as a condition where there's excess body fat that's impairing health. And so I think of using BMI as an initial screening tool, but actually it doesn't always fit, and the person in front of you actually will always matter. There was a recent commission through the Lancet that put out a statement saying that we really need to redefine BMI or body, or how we defined obesity. BMI, again, being one portion of it. But there's other ways for us to define obesity that are sometimes missed if we simply use BMI. And the other part of it that this statement said that I think is really important is thinking about the effect of obesity on other organs. That's when it's clinical obesity. When we just identify somebody with excess body fat, but they don't have involvement of certain conditions, we would call that now preclinical obesity. But we do recognize when you have preclinical obesity, you are already at a much greater risk of developing both clinical obesity, where it affects organs, cardiovascular disease, some forms of cancer, as well as diabetes, and also impact on your body function that can complicate other and create other health issues. But in this statement, they also talked about the other ways to define excess body fat, and BMI being one of them, but also accepting waist to hip ratio as perhaps a better way. And there's a lot of data showing that waist to hip ratio is actually a better way to define excess body fat, but also waist to height ratio. And those can be used as well. There's another way to define obesity, and that's to directly do some sort of body scan. A DEXA scan is a common test that can be used. And that can tell, even when somebody might look skinny, but we see that they have excess fat deposit in organs and in the body. So I think that this might be a new way of defining, but I will tell you that this statement just came out a few weeks ago. And so we'll see how this gets translated into clinical practice. But I really like this definition. Once obesity or excess body fat enters our organs, that's when heart problems and other issues start really being an issue. And the heart, of course, I'm a cardiologist, but I do recognize that the excess body fat can infiltrate the liver. It can infiltrate the kidneys. It can infiltrate the lungs and cause things like sleep apnea, but also can cause other lung issues. It can infiltrate into skeletal muscle. And then, of course, it can affect the heart functioning. So all of these organs that get affected by excess body fat are important, and of course, reasons why more than just cardiologists care about weight. And we know, at least, and again, I'm going to present this really from a cardiologist perspective, given what I do every day, but if you don't have other cardiac risk factors, but you do have excess body fat, you are at a greater risk of developing heart disease, cerebrovascular disease, or heart failure. So we show this, like, if you have a number of risk factors, of course, your risk is greater, but even without any risk factors, so by our standard screening tools, using your blood pressure, using your glucose, using your cholesterol, your age, etc., when we plug in that doesn't always take into account excess weight. And yet we know excess weight does affect your risk of developing heart disease. So we need to think about this more in our community about when we're doing, and actually there's a new risk score that actually incorporates BMI. It has not yet entered the guidelines, but I suspect it will in the next iteration of the guidelines. We know if you lose weight, you can reduce cardiovascular risk. And how does that occur? Well, there's a number of different things that happen, but I mean, simply blood pressure reduces when you lose weight. Your cholesterol goes down when you lose weight. Your blood sugars go down, and particularly for people with diabetes or pre-diabetes, we know that the glucose goes down, but also insulin resistance goes down as well, meaning that they're more sensitive to insulin. And inflammation goes down. So that's how we think that cardiovascular risk is improving, by all of these measures improving. Now, until recently, our tools for weight loss have been quite limited and without really great evidence that it improves cardiac risk. And so this is a busy, oh my goodness, I made a better table actually. I'll go to this one. I made it better, but it's still a busy graph here. But the studies look, all these studies are kind of a summary of lifestyle surgery, medication, whatever they were looking at, and said how much weight was lost and also was it significant, was it safe. So you can see there was the Look Ahead trial. This was a lifestyle intervention funded by the National Institute of Health. It was actually terminated because of futility. Like it really didn't show a significant difference when they were looking at major adverse cardiovascular events. There was some weight loss in the people who received lifestyle compared to those who did not. But again, you can see it's a very small amount and it wasn't statistically significant in terms of saving lives. Surgery, on the other hand, we do have data that bariatric surgery does work and it does reduce mortality. It is safe. And we know that it also results in a pretty profound amount of weight loss. If you are eligible for bariatric surgery, it can be a good choice. I think that many patients don't choose it for a variety of different reasons, but it actually has evidence behind it. When we look at other medications, and of course, this has been an area of interest to our community and others for quite some time, but we've looked at the different medications. There's a medication called sibutramine. It actually was completed, but it actually increased risk. So it was never came out to market. It was not safe. Another study called the Crescendo study was actually terminated early due to safety concerns. So that didn't pan out that we could use it. We know for the naltrexone and bupropion, which is a medication that can be used for weight loss, but in truth, it showed it was actually terminated prematurely because there was, in this particular study, the study integrity was compromised. For the data that they had, there was actually really no difference. It did look safe, but you can see the amount of weight loss was quite small compared to placebo. It was really not that significant. And another medication that we had, again, proved it was safe, but it really, again, small amount of weight loss, no difference when they were looking at hard cardiovascular endpoints. There was one study called the DPP, which involved medication and lifestyle. So they used metformin and lifestyle. And again, it was completed, but there was really no difference in the cardiovascular endpoints. It was safe. There was weight loss with the intervention group, but again, very small. And then this other lifestyle intervention trial did show it was completed. It did actually reduce cardiovascular events. They didn't report anything on safety, but when you look again at the weight loss of the intervention, 1.1 kilogram per meter square, like that's not very much weight. And for people that need to lose weight, we aren't usually talking 1 kilogram. That's not what they need, really. So it can be very frustrating for patients to do so much work and then see very minimal improvement. We often, though, I'm sure for many people that struggle with their weight, they will say, I already know, I've been on every diet. I've tried every diet. Like, what else can I do? And every day there's a new diet out there saying this diet works. Well, I will tell you that ultimately there's not really a magic diet. It ultimately comes down to calorie restriction. And so right now, of course, a lot of people are talking about intermittent fasting. And again, if intermittent fasting makes you eat less, then it can be the right diet for you. But I don't know if it's the golden diet for weight loss, to be honest with you. And everyone knows, they see something, they see a new diet out there that they might be selling you something or not selling you something, but it's always a complicated story. But this particular study, they actually looked at intermittent fasting and they compared it to calorie restriction, and then they compared it to standard of care. And that one of the primary interest in the study was actually looking at glucose. Did glucose improve? Did the glucose sensitivity improve? And there may be something about intermittent fasting that does improve glucose. And it was demonstrated in this study that definitely the people who did intermittent fasting did have perhaps improvement in their glucose. But really, it came down to calorie restriction, because both the calorie restriction diet as well as the intermittent fasting diet did show weight loss, close to 7% weight loss with both intermittent fasting and calorie restriction, which was definitely better than standard of care. So just saying eat less and move more. But what was noticed in the study, by the 18th month, of course, they had gained much of this weight back. And so that is pretty common. I see that in my patients. They'll do really good for a few months. Maybe they can be motivated for 6, 7 months, but after a year, it becomes very hard for them to keep the weight off. So weight loss is good, but weight loss is really hard. And it is not due to willpower. I will tell you, most of my patients who need to lose weight, they've been struggling with their weight their entire life. It is not that they haven't tried to do the right things. And they know more actually often about diet than I know sometimes, because they've read every book, they've bought everything to try to help them lose weight. When we think about diets, and if you ask me, what diet should I be on? To be honest, I'm not usually talking about weight loss. I'm just talking about be on the Mediterranean diet, because it's the only diet that has proven a reduction in all-cause mortality, a reduction in cardiovascular mortality, a reduction in stroke, and a reduction in having a heart attack. There is, of course, from the low-fat diet, we do have data that it reduces all-cause mortality and non-fatal myocardial infarction, but all the other diets out there don't show this reduction in these two major endpoints. So it's not really a diet, it's a lifestyle, if that makes sense. And that's what I recommend, because that's the data we have. So I don't, if somebody wants to be on an intermittent fasting diet because they feel like that helps them reduce calorie intake, then I'm fine with that. I'll support them through it and make sure what they're eating is healthy. That's always the problem. The keto diet and all the other diets that have come out, sometimes they're not healthy the way that they are applied. I'm not even against the keto diet if you do it with the Mediterranean diet, meaning being healthy. If you're eating just saturated fats, then I tell you, especially for my cardiac patients, that can be a cause of a heart attack and not safe. But that's where we are with diet. What about exercise for weight loss? We all know that it is very hard to exercise. Not to minimize this. I mean, I definitely love exercise, but I know for most of my patients, this is our biggest battle, is getting them to do exercise. And just generally, as you probably all know, we recommend 150 minutes a week of aerobic activity. Doesn't matter how you get it. You can get it in 5-minute intervals. You can get it in weekend doses. There's nothing bad about being a weekend warrior, but we recommend that just for baseline cardiovascular health. But if you're trying to prevent weight gain, you need to do more. And if you're trying to promote weight loss, you need to do, up to 400 minutes a week. And if you're trying to prevent weight gain after you've lost it, you still have to do at least 200 to 300 minutes a week. I can barely get my patients to 150 minutes a week, let alone doing more. It's hard. It's hard to fit it in. We all have jobs. We all have things we have to do. We have to, of course, I think we still need to make it a priority. I definitely follow the prescription here. And I'm kind of a little bit of an exercise addict, but it is hard for most of my patients to do this. And so it's really hard when it's not even comfortable to exercise when you have excess body weight. So now we are living in a different era, which is really good. We have now 6 anti-obesity medications that have FDA approval. These are different drugs that can help. I will probably concentrate I'm going to talk about the new ones. So just these last three medications at the bottom. Orlistat can be used. Most patients don't really like it. It is quite messy, and I hope you understand what I mean by messy. But doesn't cause a huge amount of weight loss, but does at least help with weight loss. Phentermine and naltrexone and bupropion, they can be used. I will tell you as a cardiologist, I don't use them very much because they do tend to have a side effect of high blood pressure. And most of my patients already have high blood pressure. So I'm not going to risk using these medications in my cardiac patients, but that they can be used. And sometimes insurers will say, you got to use one of these before you can use one of the new medications. But generally, if you have a cardiac condition, as I know people who belong to Mendon Hearts do, they might not be the right medications for you. These new medications, liraglutide, semaglutide, and tirzepatide, these are the new GLP-1 receptor agonists. And I say they're new, but actually, to be honest with you, these medications have been used since 2005, I believe, for the management of diabetes in different forms. And we've learned a lot from people with diabetes, as I'm going to show you. But when everyone says these new medications, I kind of laugh because they've actually been around for a while. But nonetheless, they are known as the GLP-1 receptor agonists that we're going to focus a little bit on today. We are learning about these drugs every day. It's quite amazing. Again, we use these to control blood sugar. And so we knew in the pancreas there was an effect because that's how these drugs came to development. But as they were being used in patients with diabetes, we learned that patients ate less. We learned that people lost weight, and we learned about the cardioprotective effects and the effects to the blood vessels and the platelets and then the kidneys and to the brain. So there is so many things that are emerging about these medications, and I think we don't even yet fully understand the whole story. So like I told you, these were medications that we have been using for quite some time in diabetes. And what you may not know is that whenever we do trials in people with diabetes, type 2 diabetes, those medications have to be studied for their cardiovascular endpoint. The reason being is there has been medications historically that came out to treat diabetes. They didn't study them for cardiovascular events. They proved they were good for diabetes, and we started seeing an increase in cardiovascular events. So now all drugs that come out for treatment of diabetes have to show us cardiovascular endpoints before they are approved. So it's from those studies that we learned that, gosh, the cardiovascular events, not only were they safe, but they actually started having a reduction in cardiovascular events. Not just death from cardiovascular disease, but all-cause mortality, myocardial infarction, which is a heart attack, stroke, heart failure, and the composite endpoint related to the kidneys. So we were like, what's going on? These are super drugs for people who have diabetes. And that's actually how the questions, especially the weight loss that was noticed with these medications, we started asking, what if these drugs were used in patients who didn't have diabetes? Could they tolerate them? Would their blood sugars go down? And would they get the amount of weight loss? And so this has led us to a new era of medications. And these were two of the big trials that came out, one called the STEP trial, one called the SURMOUNT trial. One was studying semaglutide and one was studying tirzepatide. Just so that you guys know the name, semaglutide for weight loss or for diabetes, that is known as Ozempic for diabetes or Wegovy for weight loss. Tirzepatide is known as Mounjaro for diabetes or Zepbound for weight loss. They are the same drug, but we have to prescribe them in the right way. Don't ask, it's so complicated, but nonetheless, I'm going to talk about both of them because they kind of did the trials almost in parallel of the two drugs. I think they were chasing each other. So the STEP trials were all about semaglutide. The SURMOUNT trials are all about tirzepatide, but you can see here with semaglutide, you can see that compared to placebo in terms of the percent weight loss with semaglutide of almost 15%, that was quite dramatic. That was the first study. I'm so sorry that changed without me touching it. But we had seen this dramatic reduction. Similarly with tirzepatide at the highest dose, 15 milligrams, we saw a 20% weight loss with this medication compared with a 3% weight loss in the placebo arm. So this is pretty dramatic weight loss, particularly the tirzepatide, that's approaching the amount of weight loss we've seen with surgical bariatric surgery. We get about 25% weight loss in those trials. So this is very exciting because, as I showed you, the previous drugs, small amount of weight loss, never enough for people whose BMI was above 30. They needed to lose much more than 1 or 2 kilos. They needed to lose much more. So these were meaningful drugs. They showed in these studies that they were safe, but they were also effective. What was also interesting in SURMOUNT, they used tirzepatide again, and they looked at the patients who had pre-diabetes. And they looked at, if we treated you, what was the incidence of going on and developing type 2 diabetes? And you can see very few patients in the tirzepatide arm went on to develop diabetes, but the placebo arm, there was definitely a much higher rate. And this is weeks. I mean, I know you need maybe even longer amount of time, but you can see even in those 200 or so weeks that they randomized patients, this was pretty pronounced. So that's a good thing because we really didn't, aside from telling people to eat better to try to prevent and also, of course, lose weight, this was caused weight loss and prevented the progression to diabetes. So I think that's another profound thing about these medications. So another study, though, looked at the effect on the kidneys as well. And they looked at people with type 2 diabetes and chronic kidney disease, which is actually quite common. If somebody has diabetes, often we're always looking at the kidneys because the disease can affect the kidneys. And they saw that, again, in this FLOW trial with semaglutide, that patients who receive semaglutide, they reduced the risk of developing heart failure, they reduced cardiovascular deaths, heart attack, stroke in this population. And they also saw that there was a reduction in the progression of chronic kidney disease. And we really don't have many drugs that improve kidney function. There's just a couple now. A couple years ago, we had absolutely nothing. But now this showed that if you treat 20 people with chronic kidney disease, over 3 years, you prevent 1 major kidney event. So that's also exciting for people that have chronic kidney disease as well as diabetes. The other important trial that was that was in 2023 was the SELECT trial looking at semaglutide and cardiovascular disease. So looking at patients who had obesity, already had cardiovascular events, what was the risk of, what could you reduce the risk of future cardiac events? And they were able to demonstrate that not only did the patients lose weight as we predicted, but cardiovascular endpoints, those hard endpoints that make us think, okay, another drug that may reduce the risk of another heart attack, that was proven in this study. They did have more side effects in the semaglutide arm compared with the placebo. That's not too surprising because obviously, if you're receiving the drug, we would expect you to have some side effects from the drug. Sometimes people on the placebo arm can have those, and you can see it was almost half of them half of the number that experienced events in the semaglutide arm also experienced them in the placebo arm. But this was very exciting because this is when we started getting insurers saying weight loss isn't vanity. Because unfortunately, still to this day, helping people lose weight is not always approved by people's insurance. But when you say that it reduces cardiovascular endpoints with people with cardiovascular disease, we now have greater approval of these drugs, particularly CMS or Medicare has covered them when you have cardiovascular disease. We also had trials related to a type of heart failure called HFpEF, or heart failure with preserved ejection fraction. And we know that heart failure with preserved ejection fraction, there's something about the change in the heart muscle and the heart cells that occurs because of fat deposition and it makes the heart stiffer or not work normally. There's more inflammation. So for HFpEF particularly, we know that 80% of the patients who have that diagnosis actually are either overweight or have obesity. And so particularly treating that weight, we were like, well, what if we treat that weight? Can we again reduce cardiovascular events, and can we improve their quality of life? Well, the first trial we had was the STEP HFpEF trial. This was with semaglutide, because anytime you see the word STEP, it's always semaglutide. They showed the weight loss, but they also showed an improvement in quality of life, an improvement in the 6-minute walk, improvement in inflammatory markers. So this was really great, but they did not assess cardiovascular endpoints in this particular study. But then we had, we had the STEP HFpEF, a similar study in people with diabetes, and they showed the exact same thing, improvement in quality of life after also an improvement in weight. But then we had a study that just came out last year that was using tirzepatide, again, in the exact same population, but they looked at cardiovascular endpoints, and they were able to demonstrate that the tirzepatide arm compared with placebo had less death from cardiovascular disease and less heart failure hospitalization, an improvement in the symptoms, and an improvement in their physical limitations. So this was really exciting, and this was a game changer, because once you have that, we are waiting for the approval for these medications in heart failure, but so it's not approved yet, but I suspect it will be soon. We know for diseases like atrial fibrillation, how close though atrial fibrillation and weight gain are. And we know that for every 5 units higher in your BMI, there's a 30% higher risk of developing atrial fibrillation. So these days, when people have atrial fibrillation, we are often being asked to treat them, because even if they're going to do a procedure on them for the atrial fibrillation, it's more likely that they will stay out of atrial fibrillation or have better success with the procedure if we treat it. The data, I will admit, is quite, it's limited. That we don't have yet a randomized controlled trial in people with atrial fibrillation, but we know from the STEP trials that the people with atrial fibrillation actually felt better than those without atrial fibrillation. They may have been more symptomatic. So that's one thing. We know after ablation procedures for atrial fibrillation in those who had obesity from retrospective analysis, that patients actually were more likely to stay out of atrial fibrillation after ablation if they were started on semaglutide compared to no semaglutide. But then there's other trials that actually haven't shown the same thing. This was an even larger study. It came out this year, and they looked at that exact same question, any GLP use after ablation, and they were not able to find that there was a reduction in needing additional ablation or staying in out of atrial fibrillation. So I think we don't know. We really need a randomized controlled trial, to be honest, and I think that'll be forthcoming. What we do know, though, is that when people have sleep apnea and obesity, that patients who are on tirzepatide, in this particular trial used tirzepatide, compared it to placebo, whether people were already on CPAP or refused to use CPAP, didn't matter. They actually saw a significant reduction in the apnea episodes after 52 weeks of treatment. And so this also has been approved. Tirzepatide has been approved for people with sleep apnea. So again, what the biggest challenge for us is in the US is that We like people to be sick before we treat them. I'm a preventive cardiologist, so you have to have these diseases for your insurance to pay for them, unfortunately. I think we should be much more proactive, but the cost of the medication has really limited the access to these meds. So just the tools that we have right now, we do have surgery, and for some people, surgery is the right treatment. We certainly know that we'll get more weight loss with surgery, particularly with the traditional gastric bypass. We have other treatments, though, that can be done, like gastric banding, and they're very effective and can be right for the right person. But now, as I said, we have 6 weight loss medications approved and many, many more to come. There's many trials ongoing. Not approved yet, though, so we'll see how they land. But you can see, like the other medications, the amount of weight loss is smaller than the amount that we get from these newer GLP-1 receptor agonists. Liraglutide, I didn't talk to you a lot about it. It's another GLP-1 receptor agonist that gets a smaller amount of weight loss and can be very appropriate for somebody who's just overweight, doesn't need a lot of weight loss. And sometimes insurers will ask us to use liraglutide over semaglutide or tirzepatide solely because of the cost. I will always say it's on the foundation of prescribing exercise and diet, and together exercise and diet can help with weight loss and can cause up to 10% weight loss as long as people can stick with it. But I do think it's usually lifestyle with a medication. So the biggest issue has really been access of these medications, which relates a lot to the cost. And that's why people are saying, well, if you have clinical obesity with organ dysfunction, those are the people we should be using these medications in, that we can't afford necessarily as a health system to treat everyone with obesity. I don't know. I mean, I hope the cost of these medications go down, because I am a preventive cardiologist, and I do think that if we attack things earlier, we can prevent heart disease, and it would be better to do a lot of this upstream than downstream. But we know in the US, obesity is a common issue. We know that 40% of the US population is either overweight or obese. And 45% of the US population, actually, technically, if you take all the studies we've done, 45% of them would be eligible for these medications. And if we could give everyone the medications, we could reduce deaths by about 42,000. This is Dr. Pandy, our colleague of mine, did this sort of hypothetical. If we treated everyone, what would happen? And he even said, right now, the amount of people getting these medications is really going to barely shift the curve just because of the cost of these medications. But if we expanded the access, the green curve here, we would shift the BMI completely. And that would be a good thing, because we do have in the US and around the world a lot of people with a BMI above 30 kilograms per meter square. And we haven't really had great treatment to help them until recent. We know there's a lot of things we could talk today about nutrition. Yes. Do we need to do better about the nutritious source of food? Yes, but that costs money too. And we have not done it as a society. We have not improved food security. We have not made it possible for everyone to have access to nutritional food. In fact, nutritious food costs a lot. It's not that affordable. And depending on where you live and the community that you live, you may not even have access to fresh, good food. So that always is an issue in the United States and actually around the world. The challenges with these new obesity medications really comes down to their cost and our coverage issues. And in reality, some people can access these drugs, some people can't. And it's just widening the gap in healthcare. And I think that there's med spas that offer these medications that are compounded, which are highly unsafe, and we do not encourage them, because there's no standard for compounding pharmacies. We know that a lot of the hazards and problems have occurred in the places that have not been prescription based. So I think this is, we've got a lot of work to do as a society about our public health and how we improve care, but also how we improve health for everyone. I think that, the good news though, I will leave you with is that, we've always been trying to manage obesity. It's never been that easy, but now we have much better medications that make it more possible. We'll have new risk scores coming out. They're going to include the BMI. That will be helpful too. And I also think that when we use these newer medications, it can improve not just cardiovascular health, but diabetes, sleep apnea. I'm showing you kidneys, etc. There's so many cool things that we're seeing about these drugs. The problem is right now, the lack of access, the lack of coverage. Some people get it, then they don't get it. Weight cycling, when there was a shortage, there should be no shortage anymore. We need to work on our own barriers, our own structural policy, population level interventions. But the good news, I hope, is that we can help people that already have excess weight, who already have heart disease. It tends to be easier for us to access these medications and working and choosing what is right for that individual. For some people, surgery will be right. For some people, medications will be right. For some people, lifestyle will be right. And for some people, we may need one or two or all three. So I will stop there, and I know we'll have time later after Jessie presents for questions.
Thank you, Dr. Gulati. That was incredibly thorough and just really informative. Jessie, we're going to invite you. I think we're going to put you on spotlight now and just invite you to share your very powerful and I think unique story that others can learn from.
Yeah, I started once I got my LVAD, my weight shot way up fast, and I had to learn how to eat food again in the right portion sizes because my body was getting all the nutrition that it needed and more. After dealing with weight management doctors and my then they decided to put me on injections, weight loss injections, about 14 months ago now. And I had a BMI of 46.6, and today my BMI is 35.5, being on the weight loss injections. And I've learned how to eat. And I'm exercising. And basically, without the injections, I wouldn't even be on the transplant list for helping myself to move on with life. The injections to make it a lot easier, but you have to deal with your insurance company on them deciding if they're going to cancel one injection over another one, then keep on switching you back and forth throughout the year. I am down a total of 59.5 pounds as of today. And I just keep on going every day, trying to do as much as I can with my heart issues and my weight. But I am active on the transplant list, and just like to say the weight loss injections make a big difference in my life. Sometimes they're hard to get, but that's getting a lot easier now. That's all I really got. I mean, besides having to deal with just traveling and everything on top of it. And that's all I got, Mandy.
Yeah, Jessie, do you mind explaining for the audience, because I don't know if people are aware that about how the transplant list works. And so if you were to not use these medications, what would happen if your BMI didn't come down?
Well, I need to have a BMI under 40 right now. So I made that halfway through last year, back on the list again, halfway through last year, and I've been active on the list. When you go for a transplant, and you get your transplant, your body the heart can be within -5 pounds to +20 pounds of your body weight. So trying to find a heart for a bigger person is a lot more difficult than it is for a smaller person or a smaller frame person than what it is for the larger frame people.
Thank you for explaining. And why don't we, Tammy, go ahead and bring Dr. Gulati back on the screen as well. And I actually, Dr. Gulati had a question based on what Jesse just said about, I've heard many advocates who are on these medications talk about the importance of continuing positive lifestyle trends as well as being on the medication. Can you just talk about how important that is?
Oh, yeah. I mean, you can't, that's why it's frustrating when people go to med spas to get these medications or don't follow, aren't under the care of a physician. You do need to be under care of a physician when you're taking these medications. And a lot of it is to learn also, it's one thing to use the medication, but it's also to address the other things. What's the underlying cause for the excess weight gain? That is one part of it. And one thing that makes it definitely easier when you're on these medications, it's much easier to address, let's think about the signals about why are we hungry? Are we not hungry? Because later on, maybe that now, I'm not saying everyone will go off these drugs. We do think of obesity as a chronic disease, but maybe depending on the dose, or for some people, they might get off of them, but you want to be able to learn good eating habits. And we want you to start exercising too. And it gets, of course, easier to exercise when you've lost weight. It's much harder to tell people to exercise when you're carrying a lot of extra weight. So we want those things to be part of the prescription, if you will. If there's a behavioral reason for why you gain weight or why you eat, which a lot of people have. It can be psychological. It could be that you're depressed. It could be, if you have a history prior of bulimia or anorexia, those things need to be addressed because otherwise, you are just going to never really be able to break free from them. Because they're ultimately contributing. So then you'll be potentially at the highest dose of these medications, and it might be lifelong. And and we're learning how long would these medications need to be on. So I think it's important. I think everyone should meet with a nutritionist if they're on these medications or a dietitian, because they can really create a good health plan for you. The other thing that's really important to recognize about these medications is that not only do you lose fat, but you also lose lean muscle mass. And so we don't want you to lose too much muscle mass, but you can lose anywhere from 20 to 50% of your lean body mass. So again, this is why when you're on these medications, it's important to be talking with a dietitian about your protein intake and making sure you're maintaining enough protein to retain protein or retain your own muscle mass. And then additionally, you should be doing some form of resistance training when you're on these medications so that you don't lose so much muscle. That's what we don't want to lose. We want to lose fat, but we don't want to lose muscle. And I think that that's an important part of working with the entire team that's taking care of you.
Yeah, that's really important to note. And when you talk about the lifelong, the possibility that some people may be on this their entire lives, has there been any evidence of intolerance after a certain amount of years, or has there not been enough data?
There's probably not enough data. We'll probably gather that in time, but we certainly know from the early trials of weight loss, like the patients who went off of it, the participants who went off of it, many of them actually regained weight. They didn't go right back to their starting weight, but that they gained at least half the amount of weight back. And so I don't think that's that surprising. I mean, there's a lot of things in our genetics that dictate where our weight likes to be at. We're almost fighting that a little bit with this too, with these medications. So I tell all my patients when I meet with them that this excess weight, having obesity, it is a chronic disease. And just like high blood pressure, most likely we're going to have to treat it for your lifetime. The doses I can't predict. For everybody, it's a little bit different. And so we've worked around that, but we don't have enough data to really know. But for some patients, I would say even in my clinic, some have been able to go off of the medications. They've been very dedicated and regimented and really use the time to figure out their eating behaviors, and we're able to, I guess, correct it. We'll see how long it lasts, meaning, you know, there may be a time where habits come back, or if it's stress related, if stress comes back, then they may regain the weight. But generally, I think that's the way to look at it, that it's a chronic disease and you might be on these medications for life.
Quick question from one of our attendees. Should it be your cardiologist diagnosing these medications, or is just your primary typically would do it?
Be either. It depends if, I mean, I know people here online, most people have a heart condition, and so they might see a cardiologist. I will definitely say that management of weight and management of diabetes, I will always say it's still a cardiologist's job too, but we partner with our primary care physicians as well. I don't think you have to. It depends who's comfortable. And I think that that's when you bring it up with whoever you're meeting with. If you need weight loss medications and you're in the family physician or the internist office, I'm guessing most of them will be comfortable prescribing it. I think the biggest challenge has been getting the medications. I think it's easier when you have a cardiac condition. We know how to document it and say, look, they have a cardiac condition. It's easier to get approval. The hardest part is the people without cardiac conditions that are approved for these medications, then the expense is quite high.
Yeah. And I did want to bring that up and bring it back to Jesse for just a moment, because Jesse, when we were advocating in DC a few weeks ago, you had talked about the financial toll that this takes, which can't be good for you when you're on the transplant list. Are you able to just highlight that a little bit? Because that's so important to the argument that's going on right now for coverage of these medications.
Yeah, I can talk about that. With my weight management injections, they're running me about $700 a month. Some months they're cheaper, but most months are about $700 until I get on my donut hole, or $1,000. Then they'll drop down to about $390 a month on average.
It's a huge amount of money for people. And Jesse, if you don't mind me sharing on your behalf, because of you're not able to work, is that correct? Because you're on the transplant list.
Yep, and with the LVAD.
And with the LVAD, yeah. So just so our audience is aware of the financial pressures because of the price of the medications, like you said, Dr. Gulati, hopefully they come down. But we're getting close to the hour. I did have one other question that came in before. Dr. Gulati, are there certain people, especially if they have thyroid issues, that these medications actually can cause weight gain in rather than weight loss?
Well, I mean, the contraindication to using these medications is if somebody has certain forms of thyroid cancer or a family history of them, but not having a thyroid condition isn't precluding you from using them, but also shouldn't affect your thyroid condition if you're adequately treated. So seen that if you're having an issue, make sure that they're checking your thyroid levels to make sure those are good. I'm sure whoever monitors that will make sure as well, but not something that we worry too much about as long as that's managed.
Okay. Yeah, I think in this case it wasn't managed correctly, and that was the problem. So, but I don't see any other questions in our chat. Honestly, the presentation was so thorough. You answered almost every question that I had coming into this. So Thank you, Jesse, for sharing your personal story. Thank you, Dr. Gulati. You are such an incredible leader in this area, and we're just grateful to have your voice today. So,
Thank you.
yeah, and to everyone who's on, thank you for being on. We hope to see you on our next session. So have a good evening, everyone. Bye-bye.